نبتدي سيشن 1 في الميتنج ان شاء الله بالمحاضره اللي هيقدمها بروفيسور دكتور عمرو المليجي Diabetes in the Elder People. دكتور عمرو اتفضل.
بسم الله الرحمن الرحيم. أنا أتكلم على diabetes and elderly. أول my agenda demography of aging and epidemiology of diabetes in older adults, altered glucose metabolism with aging, health hazards in old adults with diabetes and diabetes care in older people. أول حاجة demography. As shown, elderly is defined as chronological age 65 years or more. Global human lifespan increased from 47 years in 1950 to 73.6 years in 2022 and is expected to reach 78.1 in 2080. This is attributed to shift in the leading causes of diseases and death from communicable to non-communicable diseases. Here this slide shows number of people, older people with diabetes in 2000 was 56 million all over the world. In 2030, expect to be doubled. 30% of people in the MENA region are 30% of people above 65 years have diabetes. This is diabetes. This is the IDF Atlas shows prevalence of diabetes according to age. 30% of people above 65 years have diabetes. Does glucose homeostasis change with aging? This slide shows the changes that occur in old age and result in diabetes. First, effects on the beta cell dysfunction and factors that increase insulin resistance. Beta cell dysfunction occur due to mitochondrial dysfunction, reduced GLOT2 levels, advanced glycation end products, telomere shortening, impaired calcium ion handling, and reduced response to GLP-1 molecule. Also, obesity itself, sarcopenia, increased muscle fat and visceral fat, ages, free oxygen radicals. All these factors, hyperinsulinemia, all these factors contribute to insulin resistance. A majority of older adults with diabetes are type 2 diabetes. Either older age onset, diagnosed at age 65 years or more, or middle age onset, that's diagnosed in middle age and continues. Microvascular complications, especially retinopathy, are more common in the middle age onset than older age onset patients, but both are at higher risk of cardiovascular diseases. Health hazards in older adults with diabetes. In older adults with diabetes compared to those of the same age without diabetes, there is higher earlier mortality, especially from coronary artery disease, more comorbidities as hypertension, cardiovascular disease, and stroke. Also higher prevalence of geriatric syndromes as polypharmacy, cognitive impairment, sarcopenia, functional disability, frailty, depression, urinary incontinence, falls, and this result in fractures and persistent pain. Screening of geriatric population for geriatric syndromes in older adults with diabetes is mandatory as this may affect diabetes self-management and diminished quality of life. Older adults, first I will speak about cognitive impairment. Older adults with diabetes are at higher risk of cognitive dysfunction or cognitive decline, which ranges from slight cognitive impairment in memory to overt dementia. than those without diabetes of the same age. Risk factors: poor glycemic control, longer duration of diabetes, hypoglycemia, also recurrent falls. Recurrent falls is linked to hypoglycemia. Impairment of cognitive function. Impaired ability of self-care results in impaired impacts of cognitive impairment. Impaired ability of self-care procedures like glucose monitoring, adjusting insulin doses, and achieving the patient glycemic goals, and increased risk of hypoglycemia. في سلايد لوست، بس هي السلايد اللوست دي المفروض ان بنعمل سكريننج للكوجنيتيف فانكشن المفروض از كلينيك. معلش مش موجود. المفروض يتعمل سكريننج. we should screen older people for cognitive dysfunction at the beginning of as first visit and annually or according to the condition of the patient. Cognitive dysfunction is graded according to the severity. This is this is one. This is screening for early mild cognitive impairment should be performed in adults 65 years or more in the initial visit and annually, were graded according to the severity. لو 19 to 23/30 the mild impairment, from 10 to 18 this is moderate impairment, and from 0 to 9 this is severe impairment. The test our chart is many mental state examination test and there is Arabic or Egyptian charts to help the physician to ask the patient. Sarcopenia and functional disability. Sarcopenia is age-related loss of muscle mass and strength. This results from impaired protein synthesis and increased protein breakdown. This occurred due to insulin resistance in the muscle, hyperglycemia, obesity, increased visceral fat, advanced glycation end products, oxidative stress, and inflammatory disorders. Acceleration of sarcopenia, especially in lower limbs, results in functional disability, more weight gain, more poor glycemic control. Poor glycemic control and longer duration of diabetes are the main risk factors to sarcopenia. Peripheral neuropathy, arthritis, and stroke also aggravate the functional disability. Again, functional status is also categorized into categories according to some instrumental activities of daily living, as telephone use, managing money, housekeeping, taking drugs. The patient is asked or his relative about these things, and are either classified to either independent or assistant required or dependent. Frailty. Frailty is increased vulnerability of adverse health outcomes due to decline in physiological functions and reserve in different bodies. Frailty is better predictor to mortality than chronic age. Frailty can be examined, is present if 3 or more of the following are present: unintentional weight loss, self-reported exhaustion, weakness, the hand grip weakness, slow walking speed, and low physical activity. Does diabetes care differ in older people? Diabetes care in older people should involve all domains, the glycemic control, and this is according to individualized goals, according to the patient, frailty, cognitive function, comorbidities, physical ability. All these factors affect in the individualized goals. Using individualized therapeutic interventions also, as patient if there is difficulty in cognition, difficulty in decreased vision, there is living alone is difficult for the patient to use insulin. Also, avoiding hypoglycemia. Screening and prevention and management of microvascular and macrovascular complications is mandatory. Also, cardiovascular protection. In addition to screening for geriatric syndromes, screening for depression, و preservation of quality of life. Management of older adult with diabetes is challenging because the wide variation in cognitive function and functional status, comorbidities, and life expectancies. Only few clinical trials. Why is this difficulty? Only few clinical trials addressed or the old age specifically. Most studies involved old age patients or subjects as a part of the study, but few studies only addressed old age specifically. طيب في قدامنا هنا يوكي بي دي اس زي ما حضراتكم شايفين excluded يوكي بي دي اس excluded the old age patients. Accord, Advance, and VEDIT. The three trials found no cardiovascular protection from tight glycemic control in older people. Some studies found an increased mortality is associated with increased A1C more than 11%, and increase also mortality if A1C less than 6%. Patients old age with diabetes are liable to hypoglycemia ليه؟ Age-related progressive decline in GFR, poor irregular food intake, hypoglycemia and awareness, blunted physiologic response to hypoglycemia, and unidentified cognitive impairment. Management of hyperglycemia in old age should be individualized. For like this elder patient, he is healthy, classified into three groups. Healthy group, patients with few comorbidities, normal functional status, and intact cognitive function. هنا A1C goal is less than 7.5%. Fasting from 90 to 130, bedtime from 90 to 150. For this patient with intermediate group, classified as intermediate group or complex morbidity, she has multiple morbidities, but she لا هي انا خلاص انا بخلص
معلش conclusion معلش بعد اذن حضرتك.
Okay, complex or patients with multiple comorbidities, but these comorbidities are not end organ failure, not renal failure on dialysis, not مثلا advanced or untreatable cancer. These patients are treated to A1C goal less than 8%, fasting from 90 to 150, bedtime from 100 to 180. Patients with end organ failures with severe cognitive dysfunction as dementia or severe disability, physical disability, managed with A1C less than 8.5%, fasting from 100 to 180, bedtime from 110 to 200. Physical activity is important. Dietary control should not is asked if or is advised if the patient is overweight. Physical exercise is very important, balance and strength exercise, also aerobic but under supervision. بالنسبة للدrugs, I see in metformin D4 are the best, in my opinion, the best drugs for old patients if no contraindication to metformin and the patient can tolerate. However, GLP-1 receptor agonist and sodium glucose transporter 2 inhibitors can be reserved to patients who have compelling indications زي renal protection, محتاج renal protection or cardiovascular protection. Insulin exposes the patient to high risk of glycemia, but is not a contraindication to use insulin. The old age itself is not a contraindication to use insulin and use along the needed indications. But we have to simplify the regimen. Also, selecting the patient is very important. Screening the patient for genetic syndromes, vision, economic factors. All of these factors are important. Simplifying insulin regime is important. Basal insulin, you can give it in the morning instead of the evening. Premix insulin is replaced by basal insulin. Bolus insulin, if the patient uses more than 10 units per day, give half the dose and give drug with low hypoglycemic potential زي D4 inhibitor. If less than 10 you can omit it. don't give short-acting insulin before dinner at night. Take-home message: older persons with diabetes are at higher risk for earlier mortality and comorbidity than older people without diabetes. Older persons with diabetes have higher prevalence of cognitive impairment, functional disability, and frailty. Avoiding the hypoglycemia is essential target in the management of all adults with diabetes. Assessment of cognitive dysfunction, functional status, frailty, comorbidity, social and economic conditions provide a framework to determining the targets and therapeutic approaches. Relatively healthy older adults with significant life expectancy should receive diabetes care with goals similar or near to the younger adults. In patients with significant comorbidities, cognitive impairment, functional disability, and limited life expectancy, glycemic goals are relaxed to goals that prevent symptomatic hyperglycemia. And thank you.
ثانكس دكتور عمرو. هي حضرتك وضحت لنا الموضوع بشيء من التفصيل، ولو في اي حد عنده كومنت او ديسكشن ان شاء الله at the end.